So a lot of oncology is going to be covered or has been covered as you guys have kind of gone through. So what I've done is I've kind of focused on skin and soft tissue. We'll also talk about gastric, because I think tomorrow morning you're getting foregut, but there's so much benign stuff that gets covered, just so, even if you hear the malignant stuff twice. And then we'll do a little potpourri at the end. I can't see the chat function as it comes in, so as we go through the section, we can either pause for a minute so you guys can ask questions, or I'll just continue to go. I know you're all probably in the middle of Zoom fatigue and anyway, after being bombarded with information. So,
Dr. Alina, just really quick, can you put it in the presenter mode by any chance? Or do you have questions?
No, I can. How's that?
Great. And if there's any questions during the lecture, do you want me to just let you know, or you want to wait till the end? I don't want to interrupt you.
Whatever's easiest. I'm pretty adaptable.
Okay, great. Thank you.
So, starting in medical school, you guys have always looked at the ABCDEs. It's an easy question that people will ask. Usually what I've seen in some of the questions really is that diameter. So if you're going to, things to put to memory, is this 6 millimeter. It comes up in kind of Q banks and things of that nature. In real life, though, you're looking at the ABCDEs, and then usually the F, which is the ugly duck sign. You can see what rhymes with duck, why we call it the F. But that's kind of like which one of these doesn't look like the others, and that's why people do a long-term dermatology fellowship. So again, just remember that 6 millimeter, because that's kind of a factual question that can come up on the ABSITE or if you're taking your boards at some point. So melanoma in general, right, we think about these things with your Fitzpatrick classification, which takes into account whether or not you have a fair complexion, people who are red hair, lighter eyes at higher risk, and that's because they have different type of melanin and also have sometimes some different genes that affect pigmentation. So UV exposure, and it's UVA and UVB. UVA, that's the one that penetrates deeper. UVB gives you burns. So if there's a question on the ABSITE, UVA is what causes melanoma, right? Because that's a deeper penetration, because remember melanocytes are at the epidermal-dermal junction. B is burns. So things like basal cell and squamous cell, that's going to be more associated with UVB. Now, generally speaking, if they asked you about risk factors, sunburns, if you had dysplastic nevi syndrome, people who have a history of atypical or congenital nevi increase their risk for melanoma. Immunosuppression, other types of skin cancer, again, that usually indicates, again, UV damage. About 10% are familial, and, xeroderma pigmentosum, which I've actually never seen, but they like to ask you guys about rare genetic syndromes because, again, it's kind of a question that's got a fact, like a yes or no, that they could include. So they like to ask about the different types. Now, in some of the Q banks that I've come across, I actually think the answers are incorrect. But again, remember when you guys take your ABSITE exam, it's hard to write the questions and so forth. But again, the most common type of melanoma is what's called superficial spreading melanoma. That may be a question that you're asked. And the trunk on men and legs on women is kind of the textbook as to the most common location for that, okay? So that's the take home for that subtype. Lentigo maligna melanoma, that's again UV damage. Older Caucasian males are going to have that associated with it. Those patients have a lot more of a field defect, very hard to sometimes clear these margins, and mostly are you going to see on the head and neck. And again, this is completely associated with UV damage. Now, nodular melanoma, again, in some of the Q banks, in kind of looking at it before giving you guys this talk, some of them will list this as the most aggressive melanoma subtype. And what makes it aggressive is that it has this rapid vertical growth phase. Now, in the real world, nodular melanomas respond to things like our targeted therapies or immunotherapy, so they're bundled in with the cutaneous melanomas that really respond. So in real world, the next thing is your acral melanomas, which are most common in people of darker pigmentation, Asian populations, although we do see them in Caucasian populations. These actually are not responsive to immune therapy. So these actually have the worst prognoses. So again, I think I was looking at one of your ABSITE killer things, and actually the information is just wrong. So unlearn that from whatever you guys were cramming. And like I said, acral melanoma, mucosal melanoma, uveal melanoma, these rare subtypes actually have the worst prognosis for melanoma subtypes. If none of these are a choice, then pick nodular, okay? Now, for melanoma, the last 3 years, the whole field kind of had its head turned. So when you guys, again, are taking things for the ABSITE, you know, the questions sometimes take a little bit of time to catch up. Hopefully now that it's been a couple of years, they've caught up, but the staging system's a little bit different. Now, the things that are actually most important for you guys are thickness and ulceration. That and Sentinel Node, which I'll talk about in a minute, those are the most important prognostic information when you're talking about melanoma. And again, that's reflected here in the staging system. Again, you guys don't have to memorize this, but what you will be asked is what margin should you take? So this is the consensus from a number of different randomized clinical trials, powered to look for both local recurrence and overall survival, again, at a time when we didn't have any therapy but surgery. And again, 1 millimeter or less, it's 1 centimeter. 1 to 2 millimeters, the recommended you can do anything from 1 to 2 centimeters. Again, sometimes in these Q banks, they'll give you something in between. And I've seen a couple of them where they've given you 1 or 2 as choices, which I think is frankly a little unfair because it's kind of dealer's choice. I think in the Q banks that I've seen, I think they put the right answer as 2. Again, hopefully they wouldn't give you anything like that on your ABSITE, that they'd keep it into these categories. But you're really going to take 1 centimeter margin or 2 centimeter margin. So that's fairly straightforward. If it's non-invasive melanoma, generally speaking, 0.5 centimeters should be sufficient. Now, one thing that they can definitely ask you is whether or not to do a sentinel node biopsy. Again, common practice in surgical oncology, there's some of these that are a little bit controversial, okay? So in your mind, stick to the ones here where it's all in the green, where it's a true recommendation, okay? So we don't do sentinel node biopsies. This is just for, real world purposes, right? If a patient's medically unfit and if you're not going to act on any of that staging information, right? Why do a procedure if it's not going to change your management? Now for your ABSITE, Breslow thickness less than 0.8 millimeters with no high-risk features. So it's not ulcerated, doesn't have a tremendous number of mitoses, right? That lymph node risk is very, very low, and no one would offer anyone a sentinel node biopsy. Up until 2 years ago, this next category, this considered category, was actually different. So what's very straightforward is if you have 0.8 to 1 millimeter and it has ulceration, or if it has lymphovascular invasion, something that's suspicious, you would offer that person a sentinel node biopsy. If it's thinner than 0.8 and if it has ulceration LVI, you're going to offer that person. That's pretty straightforward, and if that's one of the situations that they give you on the ABSITE, you're going to choose that. Again, hopefully they won't give you a 0.9 millimeter non-ulcerated melanoma. That's kind of this T1B category that people are, actively debating whether or not we should be expanding and doing that. If you do get, someone gives you a silly question like that, again, that's not part of the hard, accepted everywhere in the world to do a sentinel node biopsy. So hopefully I'm not confusing you guys. But again, sometimes they ask you those shades of gray questions. So anything that's a millimeter or greater, though, that clearly gets a sentinel node. In some of the older questions, there used to be, when it was above 4 millimeters, when we didn't have good adjuvant treatments, people actually wouldn't recommend doing a sentinel node, so that's why it's still a consider. Most of the things I saw in the Q-Bank, though, I think that they were considering with this now that everyone would do a sentinel node. So just to keep it really easy in your mind, anything greater than a millimeter, you're going to choose that to do a sentinel node in a clinically node-negative exam. And in that 0.8 to 1 millimeter, just kind of look what the question is asking you. Anything less than that, unless it has LVI or ulceration, you're not going to do a sentinel node. Now, again, the DCOG and MSLT2 trials, again, still quite temporal, and should start be making their way into questions. Again, these studies now are a couple years old, as well as the management. So again, if it's underlined in red, it's important. So if they gave you a trick question, right? So if they said that a patient had a sentinel node biopsy that was positive, and it had extracapsular spread or extension, microsatellites, more than 3 lymph nodes, positive sentinel nodes in more than 1 nodal basin, or if the person was immunosuppressed, they were not included in any of the randomized trials, okay? Hopefully they wouldn't try to trick you guys. Now, the other thing that's super, super important that I think is probably going to be a question, right, is you have a patient who comes into clinic and they have palpable nodes. That's completely different, right? Those patients get a therapeutic lymph node dissection, okay? That would be the appropriate next step. So don't let them fool you in the question base. You want to look carefully and see whether or not they have a clinically node negative, in which case then we think about sentinel nodes, or clinically node positive exam, okay? Again, more and more cancers are being treated with immune therapy. Again, melanoma, renal cell, lung cancer, and the list continues to expand. So if they just, again, I would expect this more on surgical oncology boards than hopefully on your ABSITE, but just so that you've heard the words in case any of you are not familiar. So after you would have surgery, considerations in melanoma, if the patients had involved sentinel nodes or clinically palpable nodes, would be for immunotherapy agents like ipilimumab, okay, which is anti-CTLA-4. Adjuvant nivolumab or pembrolizumab, those are anti-PD-1 agents. In melanoma, if they have a BRAF V600E mutation, then they get a combination treatment of a BRAF MEK inhibitor. Now, again, sometimes they'll ask you questions about what's the highest risk for melanoma as far as metastatic spread. So local regional spread is always the highest risk, right, to lymph nodes. We don't consider that metastatic. But lung followed by liver is the highest location where you'll see metastases to. If they asked you which site of metastatic disease is associated with the worst prognosis, that would be brain metastasis. And that actually has its own separate classification as what's called M1D, because those patients do so poorly. Again, just a little bit of potpourri in case it came up. This is kind of one of those random questions. Melanoma happens to be the most common metastatic lesion to the small bowel. Now, sometimes there's a question or two about basal cell and cutaneous squamous cell cancer. What's important about these, just again for general knowledge, is they're the most basal cell is the most common cancer, right? Because skin cancer, actually, if you looked at it all together, is actually the most common cancer. We just don't have registries for basal cell and cutaneous because thankfully most of them are I'm sorry, I don't know who Maria is annotating. But it's not being tracked currently. So, you talk about something that there's over 3 million people, and that's probably much underestimated. Again, thankfully, these are not usually associated with risk of metastatic spread, although they can be in certain conditions. So squamous cell carcinoma, about 4 to 5% can be metastatic. It has very heterogeneous behavior. There's different classification systems. The head and neck is actually classified much different than extremity. For this, if you got a question, if it had anything about having poor differentiation, tumor size, particularly greater than 5 centimeters. Again, you do a clinical nodal exam on these patients. Again, I don't think that they would really ask you too much about that. For basal cell, very, very unlikely to metastasize. When you resect this, about 3 millimeter margins, you just want to get clear margins with these. Again, more if you were taking oncology boards, you may get questions about being treated with a hedgehog inhibitor, either bismuthigib or sunitinib, and both of these actually have some response rates to immune therapy. Sorry. Virginia, someone had done something about annotating, and I clicked something, and now I can't advance my slides. There's like this little green marker.
Yeah, so probably in your bottom left or right corner, you can get rid of it, potentially. Yeah, right there. Can you hit the arrow?
Nope.
Right click.
I have no idea how to get rid of it.
Yeah.
Wait, you can annotate.
Oh, there you go. You got back to your normal clicker. Can you? Oh. Anyone good with technology? Oh, there you go.
There's a thing up at the top.
Very good.
Right, sorry. Let me go back. Sorry. Sorry, Virginia, I just have a different, there we go, now it's minimized again, thanks. So other things that may come up again that are classic, things like marginal ulcer for squamous cell carcinoma, anything with chronic inflammation. So someone who has a lesion following a scar or a burn, right? You're going to think about squamous cell, marginal ulcer. Those are high-risk squamous cells. Other things that they may bring up again, the xeroderma pigmentosum for squamous cell. Gorlin syndrome is highly associated with basal cell carcinoma. Those patients get multiple basal cells. They're quite invasive. People can have hundreds, if not thousands of these. It's actually quite a debilitating disease. But again, a lot of times they'll kind of ask you questions about what rare syndrome matches with what type of disease. So this would be something to just have in the back of your mind. So are there any questions about melanoma or cutaneous before we go on to sarcoma?
The first question was, when you have palpable lymphadenopathy, you confirm it's melanoma prior to doing the lymphadenectomy, correct?
That is correct. For your boards and for the ABSITE, you would do a core needle biopsy or an FNA would be appropriate for that. And then you would get, after you did that, in real life, you would then get full metastatic staging. I don't know if that would make it into a board question, though. You could, what we do in reality versus kind of what's on the boards are going to be different, but in that setting, you necessarily wouldn't have to do that. You could also do a completion lymphadenectomy. But like I said, most of us would stage the patient in that setting. But yeah, you always want to get biopsy proven anytime you have an enlarged lymph node in melanoma, squamous, basal, etc.
Okay. Next question and the last one for this is, who gets sonic hedgehog inhibitors in BCC?
So patients who have locally advanced basal cell carcinoma, so in my practice, we have some people who will ignore these for many years, and you can have erosion of all the skin on your thigh, for example, the chest. So those we would consider to be unresectable, or at times when it's invaded into the muscle because you can't really get a clear margin. Again, patients who have Gorlin syndrome, commonly will get them, or patients who have metastatic basal cell carcinoma.
That's all the questions for those topics. Thank you.
So sarcoma. So sarcomas, generally speaking, they're solid tumors of mesenchymal origin, right? So that can be soft tissue, fat, bone, muscle, right? Anything you can think of really as a catch-all. So 12,000 cases a year in the United States with about 5,000 deaths, which is pretty high for something so rare. Now, up until this year, there were 80 subtypes. There's now, I think, 110. The WHO just reclassified them. But if you can see from this little tree here on the side, right, the idea is you're not going to memorize all of these. And each time, again, in your clinical practice, unless you do these all the time, you really should kind of look them up because they're so rare. Now, generally speaking, about half of all sarcomas, just if you bundle them all together, are able to metastasize. The other ones are going to be locally aggressive. Again, they can arise in any location. And again, the treatment and staging is actually different depending upon the location, whether or not it's extremity, whether or not it's in the abdomen, and also for some subtypes which have had more research. So again, things that come up in question banks and sometimes on your ABSITE is what are the most common, and it'll be broken up between extremity or retroperitoneum. Now, thankfully, liposarcoma is the most common sarcoma, either in the extremity and trunk or in the retroperitoneum. The second one is either undifferentiated pleomorphic sarcoma or malignant fibrohistiocytoma. Okay, you don't have to say that 5 times fast. But these two things you should commit to memory for extremity, just because they do come up. If we're talking about these as far as risks, leiomyosarcomas, those can be pretty aggressive. DFSPs are usually only locally aggressive. Synovial are kind of a unique subtype. They have actually their own NCCN guidelines. These can actually metastasize to lymph nodes. Malignant peripheral nerve sheath tumors are some of the worst actors that you'll find. They're highly, highly aggressive. And again, for real life purposes, myxofibrosarcomas are actually also a unique subtype. They can grow through fascia, and they can actually metastasize to anywhere where you have fatty pads in the body. Now, for retroperitoneal soft tissue sarcomas, again, liposarcoma is the most important. High chance of having local recurrence. These can metastasize when they become dedifferentiated, and then they become aggressive. Usually they'll spread multifocal in the abdomen, but they can also metastasize to the liver. Desmoids in the abdomen are usually associated with FAP. And now that people are doing so much better with colectomies and surveillance, desmoid tumors become a really unique problem in the abdomen because they have a propensity to grow in the mesentery and become unresectable. GI stromal tumors we'll talk about because that's a favorite on the ABSITE, and I'll give you guys kind of the highlights of that. And then leiomyosarcomas, again, these are muscle tumors, so depending on where they arise in the abdomen, they can arise from the esophagus, the GI tract, intramuscularly, and these and uterine probably being the most common that you would find within the abdomen. And again, these can be highly aggressive, particularly if they're high grade. So again, they always like to ask you guys kind of these esoteric risk factor questions. So radiation, so you can have radiation-associated angiosarcoma. So if you have a question where you had a patient with an early-stage breast cancer who got treatment and had adjuvant therapy, and now they've got kind of this raised purpley lesion on the breast, it's a radiation-associated angiosarcoma, and that's a terrible disease. Undifferentiated pleomorphic sarcomas, myxofibros, malignant peripheral nerve sheath tumors, those also that have radiation as risk factors. Again, lymphedema, and that's that Stewart-Treves syndrome. Again, the setting of a patient who had breast cancer, radiation, lymphadenectomy, have lymphedema in the arm. Again, it's going to be angiosarcoma. Vinyl chloride exposure, Gardner syndrome with APC, as we already talked about, for desmoids. In a young person, if they say, you have a 20-year-old who's presenting with a sarcoma, you're going to think about Lymph syndrome. Neurofibromatosis type 1, these are the patients who are riddled with thousands of these neurofibromas. They actually have to have special surveillance because they're at high risk of getting both malignant peripheral nerve sheath tumors and GI stromal tumors. The Carney syndrome with the succinyl SDH mutations, those are also going to be associated with paragangliomas that I think you guys probably heard about during the last lecture. This is the Gorlin syndrome, patch mutation associated with rhabdomyosarcoma, but also associated, as we talked about, with basal cell carcinoma. So again, they like to ask you guys in general terms, right? These are the questions I used to hate when I was taking this test because there's a lot of genes, there's a lot of tumor markers, there's a whole lot of other things. But the things to kind of highlight here, liposarcoma, because remember, liposarcoma amongst sarcomas is pretty common. So you want to know liposarcoma, MDM2 amplification, and CDK4. That's actually something it's probably worth remembering. P53 mutations, right, with Lymph, right? That should be pretty easy to remember if they're going to ask you about that. These are so rare. Most of you will never see these, so I wouldn't put any of this to memory. When you get down here to GI stromal tumors, you have to know c-KIT and PDGFR mutations, and we'll talk about those in just a little bit. For desmoid tumors, the CTNNB1 or APC, that's kind of, again, desmoids are sometimes favorite tumors that they can ask you about, so I would put that one to memory too. Again, a lot of these other ones, I don't think they're really going to ask you guys too much about. So extremity sarcoma workup. Again, lots of the times you're going to see this on the question banks. So now, the biopsy. My personal opinions are different than what they're going to ask you on the ABSITE. So in real life, you see someone who comes in with a big lesion on the extremity. You guys are all going to say, how am I going to take this out? I'm going to assume it's a sarcoma, and you all are going to do core needle biopsies. How you do your core needle biopsy is really important because you have to actually excise that tract. Sarcomas are some of the subtypes that actually can seed other areas, and the classic teaching is we remove all of our biopsy location sites. Now, if you look through kind of the ABSITE killers and everything else that you guys sometimes will read, and again, some of the question banks that usually reflect what the board examiners will say, they find it acceptable to do an incisional biopsy, meaning you're going to cut into the cancer and take a piece out and close over, right, for something that's really, really huge. Again, in real life, please don't do that. For the answer to the board, if that's, if they don't have core needle biopsy as a choice and it's a giant tumor, right, you'll do an incisional biopsy because, again, it wouldn't be practical for a big tumor to be able to do an excisional biopsy where you remove the entire tumor. But again, for real life, either like stop and don't biopsy it and send it to a sarcoma expert, or if you're going to do something, say, okay, if I was going to take this out, let me get core needle biopsies. You do multiple cores, but you go in through the same site, each one. Now, for imaging, for the extremity, you guys, if there's a choice, you should choose an MRI because then you can really see definition with washout of the fatty components versus more solid components. You should stage the chest. In real life, if it's low grade, you can do a chest X-ray. For the ABSITE, just say that you're going to do a CT, or if it's your oral boards on everybody. Again, you don't commit this to memory. This is, kind of a 2.0 level more if you're taking your surgeonc boards, but, myxoid and round cell liposarcomas, those are different. Epithelioid sarcomas, angiosarcomas, myosarcomas, instead of having a lung predominance, those can go anywhere. So you really have to look all over for them. Again, you won't get asked for that for the ABSITE, but that's important. And again, I don't think that they'll ask you about the scare subtypes. So For the most part, sarcomas do not metastasize to lymph nodes. However, these subtypes are ones that will. So synovial, clear cell, angiosarcoma, rhabdomyo, and epithelioid. It also happens that these ones are, except for angiosarcoma, fairly responsive to chemotherapies. But again, if they asked you that, I don't know if it's worth memorizing, but just something to know. Again, the algorithm is fairly straightforward. You know, you're going to do a history and physical, you're going to biopsy, you're going to get some type of an imaging. Again, this is excisional is written here, and Amy Crago and Sam Singer are some sarcoma experts at Sloan Kettering. But again, for a lot of the board review books say it's okay to do an incisional biopsy. But again, I would just, in real life, just stick to your core. The grade, super important. If it's low grade, many times you're going to do your 1 to 2 centimeter margins. That's something that you will be asked. So you want to get at least 1 centimeter margin. If it's asked on the ABSITE, that's a solid answer for anything that you're doing. These high grade lesions, like pleomorphic liposarcomas, synovial cell, round cell, particularly, or if it's a really big high grade tumor, those patients get chemotherapy first, plus minus radiation treatment. Now, just to make things even more confusing, so this is just, again, for extremity, just focus here for a minute. 5 and 10 centimeters in sarcomas, no matter what the sarcoma is, are magical numbers, be it just extremity, intra-abdominal, okay? Now, what makes sarcomas different, and again, you don't memorize any of this, just differentiation you need to know, right? Mitotic count and tumor necrosis are important in putting together the grade. So sarcoma is one of the few types of cancers where TNM really doesn't reflect how we do the staging because, again, nodal metastases are super rare. The size can be variable, but it really is that grade. So if you get a question on the ABSITE, the answer is grade. So the histologic grade is the most important prognostic factor for sarcomas in general, okay? And what makes up a grade? Differentiation, mitotic count, and tumor necrosis, okay? And that principle will guide you through all of sarcoma, even if it's a special subtype. And again, this just kind of emphasizes the point, highly variable survival, and it's dependent upon the type of sarcoma it is and the location. GI stromal tumors, this is a sarcoma. It's the most common of the GI tract. Again, you will always get at least 1, if not 2 questions on GI stromal tumors when you're taking your ABSITE or when you're taking your boards. The best prognosis and the most common location is in the stomach. So much so that if you have a gastric gist less than 2 centimeters, you're done, right? And lots of times, sometimes these gists are found incidentally, and those patients are going to do just fine. They don't need any adjuvant treatment. If it's in the small bowel, including the duodenum, or if it's in the rectum, okay? So small bowel does worse than stomach, rectum does the worst out of any of them, okay? So the site of the GI stromal tumor is important as far as prognosis. The most common way that GI stromal tumors spread is either with liver metastases or intra-abdominal dissemination. So you get all these tiny little gists everywhere. Again, in real life, if you guys are doing a resection for a gist, you have to be super, super careful. These tumors are quite friable. And if you spill them, similar to what happens with a parathyroid, right? If you take it and mince it and spill it, you get little parathyroid adenomas. You'll get little gistlets, is what I call them, and you can disseminate someone's abdomen with sarcoma if you're not careful how you do the resection. The same thing can actually happen with leiomyosarcomas. So they took those devices off the market that they used to it was almost like a human blender that they would just rip some of these fibroids out with, because some of those women had leiomyosarcomas, and what then happened was that they had more slaters. Thank you, Mohammed. they wound up disseminating and having multifocal unresectable sarcomas later. Now, again, for your ABSITE, 95% of GIST express KIT, CD117, okay? 5 to 10% have the PDGFRA mutation, okay? Again, sometimes they like to ask you some of the less common mutations. So SDH mutations and GIST, that's the least common, but it's actually highly aggressive. It's a completely different biology, and it has an absolutely terrible prognosis. And again, if you see an SDH mutation, you have to think about those other genetic syndromes. Again, similar to the last slide, 5 centimeters and 5 mitoses, right? That is your first cutoff for when you're starting to worry and when you're going to offer adjuvant treatment. 10 centimeter and greater than 10, in real life, that's when you start thinking about potentially, even in sometimes resectable disease, about giving them upfront tyrosine kinase inhibitors. For GISTs, we give almost everybody, like I said, with some exception, adjuvant imatinib, which is a tyrosine kinase receptor. I don't know for the ABSITE, but definitely if any of you guys are going into Surg Onc, they will ask you about these mutations. So the KIT exon 11 mutation is the most sensitive, and you only have about 50% response rates to exon 9 mutations, and then most PDGFRA mutations will respond. So I'm going to pause there. Questions about sarcoma and GIST?
There was one question regarding the core needle biopsies. Do they, when doing a core needle biopsy, do you see the tract and require excision?
So, for the most part, if it's extremity, I do my own core needle biopsies, to be quite honest, so I know exactly where that is. You should talk, again, in the real world, you should talk to, if you're sending it to someone else. Or what I'll do sometimes is I will take a picture and put an X where I want them to put the actual core needle in. Sometimes it can be hard to find it because remember, if you're making a core needle biopsy, the incision, you're just going to take a little tiny 11 blade. So it's going to be this tiny little thing just so that you can get, your 18 gauge core in there to get your needle in. So again, for practical purposes, you have to talk to people because sometimes people will unknowingly go off to the periphery, and that's nowhere near where you're going to want to do your excision. So it's less than ideal. So.
And the one question was just to confirm the most common extremity and RP sarcoma is liposarcoma.
That's correct.
And the second most common cause in the RP is leiomyosarcoma, and in the extremity is your MFH.
Correct. And MFH, sometimes the nomenclature changes, so undifferentiated pleomorphic sarcoma and MFH, those combined. Okay. And the names, they keep changing the names of the sarcomas every couple of years just to make things incredibly confusing for everybody.
He loves to do this for us. Okay, last question for adjuvant therapy, TK inhibitor therapy. Do you need both greater than 5 centimeters and greater than 5 mitoses per HPF, or do they qualify with having just a size parameter?
In those, with the size, many times you will treat just because the side effects are fairly minimal. Again, that'll become, if they don't have any sign of disease, but whoever is talking, I can send you guys the randomized trial. And if you go to the Memorial Sloan Kettering site, they have a really, really nice adjuvant GIST nomogram that you can plug in various scenarios. And they actually have other ones that are sarcoma specific for RP and extremity sarcomas. So if you ever have that occasion, you're managing something, you're kind of unclear where the data will support you and what to do, those nomograms are actually pretty useful. So that's what I would recommend you plug things into.
Okay. If you want to forward that to me, I'm going to make a big compile of all the PowerPoints and additional information for the residents. But there's no more questions now.
Okay. So Again, because I'm not sure how much time they'll have with all of the amount of benign disease in foregut, plus gastric cancer seems to be something that everyone gets asked about. So hopefully they'll talk about a little bit about esophageal tomorrow when they do foregut. Things that, again, that are favorite are sometimes these really weird things, right? You need to know what a type 1, type 2, and type 3 gastric carcinoid are. Again, I think I had like 3 or 4 questions on like my Surgeon boards about this, and it's something that you rarely see unless this is something that you're a gastric cancer expert. So, type 1, atrophic gastritis. Okay, these are small. Usually they're multiple, and you see little polyps. Sometimes they can carpet the whole stomach. They grow slowly, and they rarely metastasize. Type 2 is associated with Zollinger-Ellison syndrome. Again, those are small and multiple. More likely to metastasize than the type 1s, again, but usually not common that they will metastasize. Type 3, those are the sporadic ones. They happen to be more biologically aggressive. They're usually larger at the time of presentation. They're not associated with a hypergastronemia state. And those are ones that will frequently metastasize to regional nodes or to the liver. Again, you'll get, I remember on the absite getting like 1 question a year on gastric lymphoma. Again, before effective chemotherapy and XRT, you used to do surgery. Surgery now is really only in the setting of salvage. Now, for most of these, you talk about the MALT lymphomas. If you cure people of their chronic H. pylori infection, you can have very, very high remission rates so that you don't need to give them chemotherapy. You don't need to do anything with them. It represents more of a low-grade lymphoma. Again, there are some people that will have persistent disease even after H. pylori eradication. And in those people, they'll get chemotherapy and radiation, CHOP being the most commonly used chemotherapy. The only time, again, that you do surgery is if you have someone who's perforated or bleeding or in a palliative setting. So again, the things that they may ask you, right, H. pylori association, you're going to treat them. If that fails, the next line is going to be radiation and CHOP, okay? And adenocarcinoma, worldwide, the second leading cause of death from cancer, most super common in Asia. Remember, disease in different parts of the world are different. So Western, quote-unquote, disease or disease in the United States is different than what you see around the country, around the world, and even down to how we treat this. Again, associations with risk factors. They always like to ask you guys risk factors on cancer. So these salted, pickled, or chemically preserved food, remember those are nitrates or nitrous compounds. H. pylori, those people who are seropositive have a 3 to 6-fold increase compared to patients who are seronegative. And again, all of this revolves around the idea of chronic inflammation. Familial gastric cancer, again, they like to ask you guys about mutations with all those matching columns. So CDH1 mutation, that's associated with familial gastric cancer. Those are patients who wind up getting prophylactic gastrectomies. These patients are also at risk of getting lobular breast cancer. People who have Lynch syndrome, juvenile polyposis syndrome, and Peutz-Jeghers syndrome, they have up to about 20 to 30% chance of getting gastric cancers. FAP, that risk is lower, but it's not zero. And again, as people live longer and longer after having curative colectomies, patients will get gastric and duodenal polyps that later can develop into cancer. So that's actually increasing. Again, thankfully, FAP is not common in neither of those other genetic syndromes. In the United States, again, incidence, generally speaking, of gastric cancer is decreasing. However, we're seeing more GE junction tumors, and there's a variety of hypotheses behind that. Again, if they ask you signet ring, that is a worse prognosis than the intestinal subtype, and actually we think about it quite differently. Again, basic steps of workup. You're going to do endoscopic ultrasound and imaging. All of the patients should be staged. In the setting, if they ask you a question about if you have a patient who you're going to take for resection, those patients should get laparoscopy with peritoneal washings to rule out occult disease before you do a definitive resection. In patients who are T3 or any question of nodal disease, there's a variety of different approaches. There's been lots of randomized trials. I'm happy to talk to any of you guys about these. But the things would be, if you had a patient T3 or some suspicion of nodal disease on your imaging, you can either give them neoadjuvant followed by adjuvant chemotherapy, and that's supported by the MAGIC trial. There have been other trials that have looked at more recently concurrent chemo with radiation treatment. There's trials looking at adjuvant treatment. I don't think there's clearly one that's better than the other. I think a lot of us favor in gastric cancer a neoadjuvant approach just because it's such a biologically aggressive tumor, very similar and just as bad as pancreatic cancer, where you're kind of trying to select out patients who do well. And those patients who actually respond to neoadjuvant chemotherapy are truly downstaged when you look at their survival. Again, not for your boards, just interesting. So again, if we look at an algorithm of how you're going to approach this, right, it's always, is it resectable, not resectable? Is it something that you're worried about nodal metastases or not, right? Nodal metastases, we're worried that potential nodal spread. You should really be giving these patients some type of an upfront treatment. Again, you're going to do a laparoscopy with washings to make sure they don't have occult metastatic disease, because these patients can have peritoneal carcinomatosis. Same benefit, for putting a scope in before you do a pancreatic cancer resection. And again, there's lots of then right ways, I think, to manage systemic and radiation treatment, and that's a lecture unto itself. So again, things that they like to ask you guys, right? You need to know what CWRT 1, 2, and 3 are. You just need to know what it is. As anything that's got 3 stages, right? Remember what the second one is, right? And then just know you're going to go up to 5 above and 5 below for the other 2, right? So just commit to memory what CWRT 2 is, and then just know CWRT 1 is 5 above that, CWRT 3 is 5 below that. And that's how I try and remember these things, but you just absolutely need to know that. The other thing they'll probably go over with you guys tomorrow, right? You need to know the different layers of the esophagus compared to the stomach, right? And that's actually important, right? Because esophageal cancer is a much higher propensity to spread to lymph nodes because it's missing a layer, right? Now, for the boards and for your ABSITE, you guys are going to do a D2 lymphadenectomy. And if they ask you what that means, right? So you can see here in this nice little diagram here, all of these lymph nodes here, okay? Which are pretty standard and easy to get to when you're doing your gastrectomy. This is your, I should say the other way. The ones that are kind of close to the stomach, right? These are going to be in the omentum, right? If you're doing the gastrectomy. Up here, you actually have to go up to the GE junction and fish out the level 1 and the level 2 nodes. These here that are in purple, these are your D2 nodes. So you should be skeletonizing, this is splenic coming across, but this is your left gastric, right? You should be skeletonizing all of these. You should be seeing the aorta. You should be skeletonizing the hepatoduodenal nodes and so forth. This D2, I think is incredibly important to do. Again, lots and lots of papers comparing D1 to D2, various amounts of training. But it's important to make sure that you have it for staging. If they ask you a question, you need 15 lymph nodes for your staging. Oh, 16 now? Okay. See, I'm getting old already. And that's in order to really be able to say that someone has negative lymph nodes. Now, I don't know how much time we have, but just some general kind of potpourri. So you guys all have to take basic science portion, right? They don't split the exam anymore into basic science for the 1s and 2s and then more clinical. Is that correct?
That's correct.
So I have PTSD from kind of thinking about figures like this, right? So, cell cycle, Memorize it for 10 minutes, okay? Because you're going to get a question about cell cycle. You're going to get a question about S, G, M. And if you just kind of look just in general, right, lots of stuff happen in G1, right? So if you had a guess on your ABSITE, guess G1, because it's most of where the cell cycle phases. Again, I'm not smart, but I can certainly look at a nice color picture. And that's really where most work happens, right? So this is phosphorylated retinoblastoma, which is super important. Here's your P53, your P21, your P16, cyclin 4-6, cyclin D, right? It's all happening in G1. So if you have some question, you don't know the answer, just choose G1 because the odds are in your favor. Again, you have these tables and tables and tables upon, oncogenes, tumor suppressor genes. You get asked them every year. Again, make sure that you know the ones that are common in cancers, right? You need to know what HER2/neu is, right? So here's EGFR, right? It's overexpression, right? Because it happens in a lot of these common cancers, right? You need to know KRAS, usually point mutation, NRAS, BRAF, again, super important in melanoma, although I'm understandably biased because that's my field. Again, CDK4, we've mentioned a couple of times. MDM2 we talked about also with sarcoma. They usually will ask you guys, again, BCR-ABL for leukemias, even though we don't take care of that. But it's, again, these are questions that they like to ask when you've got that whole list and they've got 5 different choices and matching the columns, and hopefully they got rid of questions like that, but I highly doubt it. Again, tumor suppressors, these are some of the most important ones. Again, P16, again, it's made it to probably about 4 different slides in this talk. RB1, super important. P53, ATM, right? Your DNA mismatch repair, you need to absolutely know these. You need to know your hereditary syndromes like the back of your hand. You need to know BRCA1, BRCA2, and you probably went over this with breast, okay? So these things are super important, and no matter what you do, they always come up on your certifying exams as well. Just quickly, you guys didn't really have an immunology section that I saw, so you'll get questions about cytokines on this exam as well, usually just 1 or 2. So interferon alpha and beta, right, the antiviral, they upregulate MHC class 1, and they're fairly ubiquitously expressed. Interferon gamma, super, super important now that, more and more attention and therapies are directed on tumor immunology. So it activates macrophages, antigen-presenting cells, enhances MHC class 1 and 2 expression. Th1, if you remember, helper T cells, right, is important in antiviral defenses. GCSF, neutrophils, it's what you use to treat some of the cytopenias. GM-CSF, use and give to patients clinically for neutropenia. Those also are important to attract dendritic cells. IL-6 is kind of one of the ones that usually is a favorite. Again, try and commit to memory, fever, inflammation, acute phase reactants in the liver. Super important for patients with autoimmune disease. And, in the time of COVID, I don't know if some of you guys have probably seen some patients actually treated with tocilizumab. IL-2, again, important cytokine, activates T cells, NK, used to be a monotherapy, is given with some of the cell therapies and CAR Ts now. IL-10, immunosuppressive. TNF alpha usually will make an appearance somewhere on your ABSITE, right? Super important, conserved inflammatory mediator. Part of a TLR stimulated by LPS. Remember, fever, coagulation, hypoglycemia, cachexia. It's a major, major mediator of septic shock. So usually some variety of these cytokines will kind of come up. And transplant rejection, Th1 responses, CXCR3 and 10. Okay. All right.
That was awesome. Thank you so much. Just a few questions. One person asked, is a diagnostic laparoscopy for gastric cancer only indicated for T1B and up, or is there any indication for it being less than T1B?
Not for less than T1B, and in fact, again, depending on the center, and particularly in Asia, they actually find a lot more of the T1A patients, and those patients actually can get endoscopic mucosal resection because their risk of lymph node metastasis is actually quite small. Again, those are usually also intestinal subtypes, which has, generally speaking, a better prognosis than if it was a signet ring.
Okay, next question is, what do you consider the epicenter of GE cancer?
The middle of the tumor.
Middle of the tumor, okay.
Like where you see the mass, and again, sometimes it's not clear, but usually they'll use the most bulky part, and that'll be determined usually endoscopically, and then you correlate that with your imaging.
Okay. Someone said, I think this refers to gastric cancer. Is it now 16 lymph nodes for a yield, or I have 15 in my notes?
I don't think the one lymph node is going to make a difference. So, but I think the important thing is you need to make sure you have adequate staging. For other cancers, 12 winds up being a magical number. I think, you can actually do a D1 lymphadenectomy, guys, if you actually have a good pathologist, and just in the omentum, they will find a tremendous number of lymph nodes. So, like I said, in order to have, they have the 15 or 16 as being a minimum number to really call someone N0. That's the important concept more than anything. Like, you need to harvest, like the same thing with pancreas cancer, right? You haven't done as good of a lymphadenectomy, or your pathologists haven't looked well enough unless they find 12 nodes, and similar for colon cancer. So that's where these numbers come from. They're not magical. It's just, you got to look, you have to look thoroughly, because in these gastric malignancies, hepatobiliary malignancies, lymph node metastasis is a death sentence.
Great. Next question is indication for regional limb perfusion and other similar treatments for sarcoma. I'm sorry, isolated limb perfusion.
So isolated limb perfusion for sarcoma is just starting to be put on trials. So you would never answer that on your boards. Charlotte Arian and Mary Sue Brady have done, and I think they may be opening up soon, a trial looking at that. Now, what's very interesting with ILP in general, so we use it less and less for melanoma, which is where it was more commonly used. But there's probably going to be some subtypes, particularly those that I listed that actually are sensitive to chemotherapy, where it will make sense. There's also some, that we think that, again, this is not for board review purposes, where how you die from chemotherapy may make tumors more immunogenic. So, for example, common chemotherapies like 5-FU, actually we think that there's a role for how those tumors die, modulate some of the local tumor immune microenvironment. So that's probably something within the next decade that'll get paid more attention to. And as with everything in cancer, the more you know you don't know.
Great. Last question. Neoadjuvant for gastric cancer is for T2 or T3, NCCN states T2 or any N.
So any N is always the right answer. If you had a T2 N0, and if you took that patient for surgical resection, you would not be sued for malpractice. T3, you absolutely, because the risk of lymphatic spread is so high. So the T2, you guys can stick to the NCCN is fine. That's always a good bet. But again, in reality, not everyone will give neoadjuvant treatment for T2. And again, that continues to evolve.
Awesome. Thank you so much, Dr. Alino. That was excellent overview of Sir John. Next up.